So, zip codes. I'm like, where can we go with this? There's a lot of places we could go with this. So, I like data. My name is Jordan Johnson. I have several ventures, Bridge Oncology, but one of the biggest things probably for me is data and looking at disparities of care and where things are located. And the best way to figure that out is zip codes. And you can look at zip codes and you can tell a lot of information from medical debt to literacy rates and all different kinds of stuff. So we'll look at some of those we'll go through, but I also want to talk to you all. And I've mapped some interesting case studies out, so we'll look at some of these case studies. But this is something that the government's going to continue to focus on. So now when patients come in and we do distress screenings and different things like that, they'll do the social determinants of health screening, which is a little annoying to me because you ask the patients, like, do you have access to food? Do you have access to water? But if they answer no, the question is then, and we do a lot of work with this. If you guys know Dr. Keshav Patel, anybody know Dr. Keshav Patel over there in Charlotte, and he's got all kinds of programs set up to where then he could send them to a food pantry and get them food. So that really is the next step. It's one thing to collect the data. It's what are we actually doing with the data? So let's see here. They gave me the clicker. Ha! All right, let's talk about zip codes. And we can't talk about zip codes unless now. There we go, man. Jamming now. I told my wife, she said, you're not taking that. I said, oh, I'm taking it. I've had this since I was 6 years old. I've been waiting for this moment my whole life. So, my God, this hat is going with me. My dogs didn't want me to take it either. They chewed the back of it off, but I didn't need it. So, Smokey's with me. So, zip codes were introduced in 1963. Somebody does have the zip code 12345. That would be General Electric in New York. They actually have that zip code. So, if you ever wonder how many zip codes there are, 41,704 zip codes. I know the hash for you. It's okay. We're good to go. But 41,704. Now, why is Smokey the Bear on here? Well, Smokey has his own zip code, 20252. He's got his own zip code. So why does he have his own zip code? 1994, they gave him his own zip code because people were sending him a ton of mail. So he got his own zip code. It seems strange to me. At least 43 buildings in New York City actually have their own zip code for a building due to their size, amount of people who work in them, which that makes sense. 48222 is the only one that's a floating zip code. The J.W. Westcott 2 is a boat that actually delivers mail on the Detroit River. So these are pretty good Jeopardy facts. If you ever need good Jeopardy facts, there you go. All right, so the first three digits, if you ever wonder how it's split out, these are your first three digits of your zip codes. I know you can't take a guy serious in a hat like this. It's tough. I know, I understand. There was a meaning to it. It was there with old Smokey, but that's your first three digits of what these actually look like in zip codes. You can see how they're split out, and it's actually split pretty evenly among states, not necessarily among population and population density. So your zip code, and there's been a lot of research done on this, and you'll see more, actually carries more weight on your potential health and your health outcomes than your actual genetic code. So, and we're seeing a lot more studies come out with this, again, the social determinants of health, and we'll talk a little bit about that, but then some of the other relations, because I feel like social determinants of health is a really broad spectrum term and everybody likes to use it now. It's like the catchy word. It's like, what does it really mean and what are we really doing with it? So we'll talk a little bit about that. Bad news, life expectancy is going down. And this was obviously post-COVID, but this is a map that shows life expectancy at birth. And, the southern states, there's going to be a recurring theme here, guys. We're number one for all the wrong reasons. I'm from Mississippi. We're number one in a lot of stuff. Obesity, crystal meth. I mean, all the wrong reasons, but you got to be number one for something. Our only motto in Mississippi is at least we're not Alabama. So, I mean, if somebody's from Alabama, I apologize. Then I'll just say at least we're not from West Virginia. So, but life expectancy is going down. I find this interesting, obviously because of COVID, but this is something that either would have expected more, and we can't wait to see kind of the trajectory of the next 2 to 3 years if it's actually going to pop back up and level off. That map is interesting because it does really show when we hear about, healthcare in the South, and we'll tie some other relationships to this specific to this specific map as we go through this. And then when you guys get the presentations, a lot of the data, I try to put the actual links to it so then you can click on it and you can have it rather than, because they update these maps and a lot of the maps are interactive. So you can actually drill down to the county. We can get down the zip code and things like that. So you'll have access to it. So it makes it a little bit easier. This is just a cut of a few cities. Pretty interesting. And I'll do a focus on Chicago here in a minute. But the lowest life expectancy estimates are on the south side of the city. If you know Chicago at all, that's predominantly an African American area. And then in DC, we can see here exactly where they're concentrated east of the river. And some of you know these areas. Some of my DC people, they know exactly what I'm talking about back there. And then New York, very interesting New York's layout. And it talks a little bit about here, but just a few blocks separate in the Upper East Side with some of the city's longest life expectancies from Harlem with some of the shortest. So we start looking at this and we start looking at what does the care actually look like? What do they have access to? So we're in New Orleans. This was a study that was done very, very interesting within the zip code 70112, which we have mid-city, and then we have obviously trim, and we have the expected. So basically, they're expected to die at 54, according to the report. They're also 5 times more likely to die from heart disease than those living in the zip code 70113, which includes a central city, the central business district. So I put this on here because obviously we're in New Orleans, but I find this very, very interesting because we happen to know obviously where some of the hospitals and things are located here, but it becomes more of just hospitals. It also becomes public transportation. We start looking at that. We start looking at access to food, access to other things that we would consider, we almost take for granted in some cases. And this shifted, obviously, we saw this shift after Katrina a little bit here. So I'll talk about another one. Chicago, this is this is a straight drop down, 9 miles, actually 10.3 when I ran it. So 10.3 on Google Maps, and residents living in Streeterville versus they live to be about 90 versus just 9 miles south in Inglewood. If we go south, residents only live to be 60. And I think we just don't think about it, right? I mean, I don't know. I started looking at this data about 3 years ago, and really started to trend it. And then I started thinking with my background, like in healthcare, okay, why does this matter? If I was a hospital administrator, if I was a cancer center director, if I was anything in healthcare, what would I be doing with this data? Does it change? Do populations shift? And we'll get into that because there is a large shift in population right now. We know that there's a tremendous number of people that are of Medicare age. Where are they going? Are they staying in the rural areas? So we'll look at some of that also. And then also we'll talk about a little bit about where are the physicians, right? Primary care doctors. We know there's a national primary care. How does that affect our other service lines like cancer care, some of the more specialty care? So if they can't get a referral, one thing that we have in our favor, and I'm sure you guys are aware of, is telehealth. How's telehealth being used? And I was talking to a few people about telehealth earlier, and it's absolutely, I think it was you. Yeah, you got stuck with me this morning. But no, we were talking about it. It's ridiculous. Some states, the patient needs to be in the same state. Some states, it needs to be, the provider needs to be in the same state. Others, it's cross state lines, and there's reciprocity. It's like, guys, really, like, we need one policy here. People move around. We have the technology. Let's figure this out. And it's, as always, CMS is lagging behind. But I think it's these kind of things that really show, because this is just within, this isn't across state lines. This is within a city. And some of the maps that we've drilled down to and we'll look at is even density of physicians in that distance of 9 miles. And it's a huge difference now. And then hospitals, right? Why would there be a difference in hospitals? Nobody would ever, I will tell you this, I live in Mississippi. Nobody's rushing to build a hospital down there where I am right now. Not the best payer mix, okay? And so that plays, and we hate to think that plays a role. It absolutely plays a role. So they're going to build, obviously, if you have more commercial contracts, things like that, there may be difference in where specialty procedures and specialty physicians are located. So that's all more reason that kind of fuels things to move to a capitated payment model for certain services. We've looked at that in radiation oncology to look at an ROAPM to say, okay, just based on disease site, you're going to get one lump sum money wherever you go. That hasn't been ironed out, but I know in orthopedics, the BPCI model for hip and knee, they've actually looked at that and done okay with it. But I think all services, especially specialty services, are going to move that direction. They're going to have to. It's the only way that they can balance some of this formula out and some of these discrepancies. If you really wanted to balance the formula out, which CMS will never go for this, is you would have to pay rural physicians more than you pay urban physicians. And it's, if any of you been a part of physician recruitment, I've been involved in that process. You're not signing up physicians to go to Farmington, New Mexico, the Dalles, Oregon, parts of Mississippi, up in the Delta. You're just not. And if they're married, you're definitely not. I'm just saying, throwing that out there is not happening. They're not going. And so we've recently had that conversation with the AMA in Mississippi where we have some, I won't even say slight, very large disagreements that get heated because the AMA is very committed to physicians, and I love that. But it's like I told them, what's your plan? Like, how are you going to get them here? And the answer can't be just more money because they're not going to do that, right? They're not going to pay, but that would solve the problem. There's some other caveats of how you could solve the problem, but we won't touch those for certain specialties like cancer care. This is another cut. So anybody from North Carolina? Yeah, what part? Jacksonville, I like it. So this would be Fayetteville, as we say in North Carolina. See, I like it. And you can look at the life expectancy. And I'll tell you what, if Fayetteville has any more commercials about the water, I don't know what those attorneys have spent, but those commercials are everywhere. Y'all know what I'm talking about? Like, if you're at Camp Lejeune and you drank water between the years of 2000, I'm like, what? That water was so bad. That water was bad then, exactly. That's exactly right. Put me in the lawsuit. Like, everybody's in that lawsuit. But it was very interesting. So this map will actually go, when you get access to it, it's a census tract map, and you can actually look up. So you can look up an overall city and then drill down to the zip codes within the city. And it'll split everything up so you can actually see anywhere. And again, I just picked one. I didn't want to pick multiple, but you can see just the difference, obviously 65.2 to 84. And then it'll give the range of what it is, high to low, and then where the average is and falls. And it's very interesting when you start moving the cursor just over, a 25, a 50-mile radius. It really, really starts to change. Which, again, it's interesting. I think this is data that the data has been around. We're just not really starting to look at it and see how it can apply, especially to preventative care, screenings, things like that. Health equity, another term that gets thrown around and drives me nuts. It's like, guys, killing me with the buzzwords, man. They throw them out there. So it's not equal access to care, okay? What it is everyone has an equal opportunity to be healthy. And quite frankly, again, we're number one in Mississippi for a reason. We outweigh most of you. I'm just saying that's by the facts. It's by the book, which means we have a higher percentage of diabetes. I'm just saying, it just goes downhill. So we love Halloween down there because lots of candy, and it just adds to the problem. But do you have an equal opportunity to be healthy? And do they have equal opportunities for care? And I think that's some of the questions that we're starting to see. And then if we do find this data out, who's responsible for it? Who's responsible for bringing the care? Is it, we meet in Mississippi. We meet with the American Hospital, or the Mississippi Hospital Association, the MHA. We meet with the Department of Health. And the Department of Health has had to pick up the ball. For the first time in the state of Mississippi, they're actually taking care of some of the OBGYN services and prenatal care services up in the Delta, which is we've had doctors before, right? Now we don't. And it's like, now they're having to step in, and that's caused some problems for sure. So, we talk about this a little bit and what are the social determinants of health. And I think a lot of things get lost, but in my mind, what all social determinants of health boil down to is, in some way, form, or fashion, it's money. Okay. It's going to go around money, whether you have it, whether you're not, whether you have access to it, whether somebody's funding a program, whether somebody's not funding a program, whether somebody has a grant, whether they don't have a grant. essentially that's what we go, what things are kind of pointed at. And I think right now more than ever, we can look at some of these and see that things are strained. I'm sure nobody else has this problem, but am I the only one? I get really pissed off when I go to Walmart and like I'm looking at my buggy and it's not near as full as it used to be, but when it rings up, it's more expensive than it's, and it's inflation, right? And I think that's very, very difficult because then I think, how does that relate to people that, people have had to cut back? One of the saddest things, and hats off to some of the people that are here and the vendors, is to go to the pharmacy and watch people have to make the decisions. And what they're making, and then they'll decide to take their drug every 3 days instead of every day because they can make it last longer. So we hear those stories from the patients, and that's tough. So again, I think you can group, and it gets a little frustrating for me because some of this is it boils down to money, and we put education on here, and even for the children. I mean, how many people have like school age kids? They don't allow me to have kids. I'm just saying. I do okay with dogs, and I even don't do well then. So, but like we helped some friends out and take their kids school supply shopping, and that was an eye opener. Like that's expensive, dude. Like that list is long. We just had some map colors and some Kleenexes when we were kids, and I don't know. Y'all didn't call them map colors. My wife says they're called colored pencils. We call them map colors. I don't know. What do they call it? Is it colored pencils or map colors? You never heard of map? It's because we colored maps with them. I don't know. Jeez, man. See, she was right. Dang it. Lost that one. Good thing it's her birthday. I'll tell her that'll make her feel better. But yeah, so that's added cost. Again, that boils down to money. So we put some of these, the neighborhood and the built environment of where you live would be the connection of where the people live, their nutrition access. Do they have access to safe housing? The interpersonal violence thing, I think that's interesting. That's some of the screenings. Any of you guys work for the doctor's office or the hospital, the violence screenings are part of the questions now. And that's the other thing is maybe patients don't feel like they can be honest and answer whether it's access to food. And I think that's the other problem, right? Is we may be asking the question, but we may not be getting the answer. So, yeah, social community and context. We'll talk a little bit about that. Economic stability, people's financials and circumstances. That's become more of I think a focal point over the last probably 2 years since inflation's continued to increase. Instability with jobs and positions. The other thing is health insurance. Very frustrating, I guess, because people are paying more. So say they have a job and they get a paycheck. Now, if open enrollment's coming up, right, and likely if you work for a company, it's going to cost you more, or more is going to come out of your paycheck just so you can have health insurance. So a lot of people simply will work a job for the health insurance, and I think that's tough. As a hospital administrator on the other side, they're looking at ways of maybe cash pay for some things isn't such a bad idea. Like it may cost people less money and they can still get quality care. That's something I've looked at. I don't know. I have all kinds of issues with a hospital down in Mississippi. We're having that battle. So I don't know. I'll tell you about it. Here it is because the CFO and the CEO appreciate it. We've already publicly shamed them. It's okay. But I had a CT scan done, and that CT scan is $168 allowable. And people are like, why are you comparing it to the Medicare allowable? I was like, I'm just using it as a baseline. Follow me here. So we have the CT scan done. And my problem is, and I'm tying this back in here because I know what patients are facing, right? So I told them before they did this CT scan, don't schedule it at the hospital. It's the worst place you can schedule anything. It's going to be the most expensive. I said, find me an outpatient imaging center anywhere but the hospital. They scheduled it at the hospital. So I recorded all this before we went in. I talked to them. I said, listen, I'll pay you the $168 Medicare allowable plus 253%. Ends up being like $350, $400. So that means that's the average commercial rate. They make some money. I'm happy. They're happy. They're not happy. They said, I have insurance. So I'm going to bill your insurance. I said, I don't like that. It's dumb. I'm going to tell you how this is going to end. They billed my insurance $4,000. I got stuck with a $1,700 bill, which is still pending. I gladly told them, send it to collections. You'll be fine. I don't really care. It's whatever. But it's just frustrating because and their comment, they can't, and it's not the people. So they leave it to the billing and collections people that are just following the policy, right? And so you got to escalate it all the way up. And then essentially what you get told is you basically offset the people that don't have insurance. That's a horrible answer, by the way. It's a horrible answer because, and it's, again, I'm not willing to pay for something. I just told them exactly what was going to happen, and that's what happened. And so it's frustrating, because what happens to the people that don't know the questions to ask, right? And they get stuck with the bills, and that's what we talked about. And I think that's becoming more of a problem. And the good thing about this and everybody that's here is, I feel like we kind of look out for each other, and people will come to us and people ask us the questions, and it's like we can make a difference. But yeah, pretty sure they sent that over to collections. So yeah, that goes. There goes. I don't know. I'll tell them, as long as it doesn't affect my credit, we'll look at it. If it does, that's what I'm married for. Can I get a cosigner? Maybe, maybe. All right, guys. So this is where things get not fun for the South. Just saying, I'm going to hold my being I'm from Texas, guys. I went to college in Louisiana. I live in Mississippi. I lived in North Carolina for a little bit. I worked as a hospital administrator in Tennessee, guys. I'm about as southern as it gets. Okay, my family tree looked like a telephone pole. Yeah, see, I knew somebody would laugh at some point. Oh my gosh. Anyway, it's all right, guys. We got 30 more minutes of this. Just drink up. We'll be okay. We're gonna make it. I know. I need to just come stay a stint in Arkansas, and then we'll be like all family. Listen, it's all good. Third cousins only. Just see, I knew somebody would laugh. All right. Median, I digress. Median household income. The South looks bad again, and all this is going to tie back into where we are with the healthcare per zip code. So you can see here where the median household income is. And the other thing I think that's interesting is, and we did an overlay, is like remote work. And, if you relocate for a job, you may relocate, based on if it's more expensive to live there. But obviously, if you take a job and you work remotely, there's likely not an adjustment there. So this was an interesting map. They'll update this probably in the next 3 or 4 months. But I mean, is there really any surprise? And I think what bothers me is people will say, okay, the cost of living there is less. True, but there are things like medical equipment. Okay, when I buy a CT scanner or buy an MRI, if I'm a hospital, I don't get a Mississippi discount because we make less money. They're going to charge the hospital the same. Any questions on this stuff? Median income. And again, you'll get the. I'll make sure the link is on here so you can get it. You can filter by state, and then you can filter by individual county. Average credit score. I told y'all I went deep into this stuff, guys. In the South, we got some bad credit. That's what happens when you don't pay your medical bill. That's what happened to me. I'm headed there right now. So apparently, but you can look at average credit score here. Yeah, we don't win for that either. Again, why would this matter? This is your ability to buy a house for housing, possibly get a cell phone, things that we would consider necessities that people may not have access to as readily available, that we may take for granted, that affect our health care. And so I thought this was worth looking at, is what those average credit scores were over time. I don't know if I have one. Let me see what the next one is. If not, I'll. So this is debt delinquency. We went again. Just Louisiana, East Texas, Mississippi, Alabama. It just keeps getting better. But for debt delinquency, and then medical debt, I don't think I put this on here, but medical debt. The South has the highest medical debt. If you ever want to know what county has the highest medical debt in the United States, it's Tarrant County. Tarrant County is in Texas. Tarrant County is Dallas. So Dallas has the highest medical debt in the United States. Yeah. You are, yeah. It gets a little better there in the very, very top, in that very corner. Yeah. Walmart's decreased the debt delinquency a little bit, but yeah, it gets worse as we slide down to Arkansas and on into Louisiana and Mississippi. But yeah, so it is a little better in Northwest Arkansas. But it's funny because it's got to be Walmart related, because if you go to the county to the left over in Oklahoma, it drops straight through the floor. Yeah, it's like 43%. No. So you can actually break that down. So yes, there's two ways you can break it down. Communities of color, it can be just African American, or you can break it down into Asian, Hawaiian, Pacific, and that. So right now, the way that I set this filter is obviously white just includes Caucasian, and then communities of color I grouped in as African American and other included into that. So Hawaiian, Pacific, Asian would include into that. That's exactly right. That's well. Listen, it's very interesting. I've got a ton. I'm from East Texas, guys. My high school was 90% black, so y'all fixing to learn a few things here. We had a good time all the time, and it's funny because I talk to my friends and like black people. We don't go to Mississippi. I'm like, guys, the whole Delta is literally 75% black. What are you talking about? But if you've ever been to the Delta, it's a very poor black community. Um, uh, what's his face is from there? Morgan Freeman. I don't like him there. He got too much money. All right, Morgan, give back. You know who else is from there? She doesn't talk about it very much. Mm-hmm. Oprah. Oprah don't come home very much. she the Delta. No, no, no. The Delta is absolutely so. A lot of people will talk about the Delta. So, like Jackson is kind of in the middle here. The Delta is like this area right up here, and it is pretty much all farmland, soybean fields, cotton fields. I mean, it's literally just there's nothing there. I have a friend that's a physician up there, and she covers for almost I forget how many counties she covers for, but it's absolutely ridiculous. People go, you drive 150 miles to see a doc, 175 miles, 200 miles, see a doctor. So I know it's crazy. So that's what we've had the argument with the AMA for, because the AMA says, well, only doctors need to provide services in our state. And I'm all for that too. But you tell me how you're going to get those doctors there. Because like I said, they're not coming. No, it's not to those areas. Serious medical debt as a problem regionally. You can look at the numbers here. It's all right, guys. I'm just checking time. I mean, I'd talk about this stuff all day long. And we got a time of a life here. We're good to go. So serious medical debt. Again, I think this is unfortunately only increasing. The problem is the hospital, if y'all listen to what Jared talked about today, is the pressure that the hospitals are putting on to collect from patients. Now, a lot of people, at least they can get on like a payment plan. And so a lot of people just pay $10 for the rest of their life, right? I mean, that's essentially what a lot of people will do is just whatever their payment plan is, which doesn't necessarily make it great, but it gives hospitals the ability to do some creative accounting. But I think right now, for a lot of people, even co-pays and max out of pockets for some people are just unobtainable. A lot of people got fooled onto obviously Medicare Advantage. We can talk about that, but a lot of people, the high deductible plans, great until you need one. And then it's like, yeah, you show up, and the people that have done the best at insurances are like orthodontists and anything with teeth, right? Those guys, you can't see anybody unless you pay in cash. So it's like, if I go in through the ER and I'd be like, I think it's bad. I think my heart's bad. You get right back. You don't have to wait. You don't have to wait at all. Pretty sure it's my heart. My left arm. So, and I'll story about Healthcare Advocate Summit and how Healthcare Advocate Summit, by way of virtue, saved my life 2 years ago. And somebody remind me to tell that story at the end because it's an interesting story. Insurance tends to lag in the South. We still have a lot of uninsured people, and I know what they say. Everybody's got to have insurance, and they sign up for it. Still, a lot of people didn't sign up for insurance, and we see that. The other thing that we see in the South is people that have multiple insurances, multiple Social Security cards, multiple driver's licenses. And y'all know what I'm talking about. I come from Texas and Louisiana, and they come in, and they would literally come in 3 or 4 different driver's licenses, 3 or 4 different names, 3 or 4 different Social Security cards. And yeah, imagine being on the front end working and trying to figure that out. It's like, who do you want to be today? So yeah, I mean, that's a problem hospitals face and people oftentimes don't think about. I don't think I put on here Medicaid expansion. Medicaid expansion was a problem. I think Mississippi wishes they had done it now. That was a lot of politically agenda driven deal. The most insured state in the United States is Massachusetts. So in 2019, and this is a really cool, I really like this one. I'll make sure the link is on there, but it's really cool. It ranks everybody's insurance by state, which one has the most insurance, Massachusetts, and then it'll show where the average is. And again, the colors in the dots, the dark blue dot is 2021, the lighter blue dot's 2019. and you can see kind of how it moves. So you're thinking some of the states are missing, right? It's all right. I'm going to the next slide. But does anybody want to guess? So just think about, again, you're going to get political, maybe politically incorrect a little bit. It'll be fine. But just think about things as a whole, things that have happened, of what the most uninsured state is. And you got to think about several things. You got to think about population, rapid population change, who the population's changing to. I'm going to give 4 guesses here, guys. Somebody is close over here. Anybody want to think about the most uninsured state? When you can see it, you're going to be like, that made sense. There's a lot of Florida guesses, man. No, Texas. And think about why, right? Exactly. That's right. They're not taking the money, and it's rapid. I mean, you got 5,000 people a day coming across the border that are uninsured. I mean, that's just the facts, and they have to be seen. They're seen. They're uninsured, and so right now, and I know you're from Texas, I'm from Texas, but that's a big problem in the state right now. That's really straining the healthcare system, and they've got to figure out how to correct some of that. Yep. We're fixing to, that's exactly what we're fixing to go. So health literacy is actually interesting. One of the most underanalyzed things, or underanalyzed aspects, and we're going to look at that because that's what I really tried to do in this presentation. Is it's great we got the zip codes. Start grabbing the facts, exactly what you're saying, the insurance, the medical debt, and start tying things in together to see, can we come up with a relationship? And yes, absolutely, there's a huge relationship to that. But I did find this was interesting, that Texas, and when I saw it, I'm like, it makes sense. United States average is up there kind of in the middle, where that line falls. So I'll make sure this link, I don't see it on here, but I'll make sure it gets added. That way, and you guys will have access. I mean, call me. I'll update these. I update them as the graphs change. I've got like a master file, and I just keep this updated because it's just good information to have, especially if you're talking with clients or working with people or working with hospitals or what's going on in other areas. Literacy. There's his slide. I got your slide. You were only, I know I did pick on Arkansas here. I'm just saying. I beat up on Mississippi enough. I beat the heck out of them. So this was an interesting map. And this map would let you, so it gives the national average of 264. Literally, and I didn't put this, every state in the South: Texas, Louisiana, Mississippi, Georgia, Alabama, South Carolina, North Carolina, Tennessee were all below nation average. Literacy matters. So, if you worked in a hospital, they'd say make it so an 8th grader can understand it. I mean, that's essentially what they're talking about. And a lot of people, they have huge barriers and don't want to admit it. We still see a lot of people in our state that can't read. And they make do, right? They try to figure it out. We have a very large, where we are, Hispanic population, don't speak any English. And so they'll either have an interpreter or a friend with them, something like that. So this was interesting because where does this responsibility lie? Is it in grade school? Is it in, should there be more accessible programs? Is it embarrassing? I mean, I've had patients that can't read a consent form, and that's tough. Go ahead. So I think the catch there is geographic location. Exactly what you're saying. Tennessee is interesting because it's got a mountain that runs through between Chattanooga, and people will do that based on, they don't want to go over the mountain because the drive's not the best, so they'll go to another area, Tennessee, for that reason. It's the reason we've told CMS and others, guys, you better figure out a way to keep these rural hospitals that are all closing and rural clinics closing open. Patients aren't going to drive. I had a meeting with United Healthcare. This has been about a month ago. Told United Healthcare what we're doing, trying to keep some cancer centers open. And they said, well, why don't we just let them close and we'll give the patients some kind of money to get them to travel? I said, that's a stupid idea. I said, have you talked to patients at all? Well, no, we think they'll drive. I said, no, they won't drive. Here's why they won't drive. Some of them don't have cars. Period. End of story. We dealt with that when I was director in Crossville. We would give people gas cards. And the problem with giving them gas cards for gas is, guess what? They didn't use it for gas. They used it for food. They used it for probably cigarettes, some things they shouldn't, but they did what they had to do. And I think that's the tough stuff. But closing centers down is not the answer, because what's going to happen then is this is our persistent poverty map. And again, guys, we win. I will tell you an interesting place, New Mexico. And I've actually been out here and worked a little bit out here. Really cool place here. It's a very big tribal area, Indians. Barbara McEnamey, previous president of the AMA, runs a cancer center out there, does some great work, but they're very much isolated out there. So again, persistent poverty, these maps will update. But again, where are these, what are the answers? What do these people do? The other thing we see really big in this area, and again, higher African-American population concentration, is ESRD, end-stage renal disease, huge, big problem. Now, population shift. This is a really cool map. So it took 2010 data, overlaid it with 2021, and then every year in between. And so what we see is where people are moving. My baseline I'll tell you to look at is Dallas, Austin, Houston. People moving there. They're green, right? Lots of people moving there. And then, you look at people where they're not moving to. Again, Louisiana, Mississippi, some of our southern areas. This is just a good map to trend the data. You can look at percent change, total population change. But this is interesting because where are hospitals located? Where is care located? What population is left? It's not commercial paying. It's not. And so what we're seeing for the first time too is a lot of Medicare eligible patients are starting to move to more urban areas. They're leaving the rural areas that they were in, and a lot of it has to do with healthcare. So another really cool one that you can kind of play around with is in 2000, we could see this, and this is population. And just watch. So this actually puts things, so I have males on the left, females on the right. I've got age on the x-axis, and then we've got, of course, the total population on the y-axis, but this is in 2000. And so we could see that the population was roughly 281 million, median age of 35.3. The percentage of people under 18 was about 25 and 25.7. 12.4% of the population was 65 and over. And watch this, it's pretty cool. It's like you're going to feel like you're at the eye doctor. 1 or 2? 1 or 2? No, this is so 2000, and then we jump to 2020. So interesting is now we're, instead of 12% of the population at 65, we're at 16.8. Median age, and again, I'll go back, median age was 35.3 in 2000, hops up to 38.8. Overall population, though, saw a really big jump. So it's, again, 331, give or take, million here. And then you can look at that again, that group of how the numbers will come down and how it expands. So again, here a little skinnier, and then really at that age of, again, 70 to 74, 65 to 69, we'll continue to see that trend over the next probably 3 to 4 years. Now, we know that those people are going to need more health care just based on age. So we're not in good shape to get that care. So these are the kind of data trends that we're looking at. Anything, what are you thinking? Yeah. Oh, yeah. See, that's the kind of data that people aren't thinking about. But people move out of necessity. Yeah, a necessity move. That is very frustrating to me, because there's no reason in the United States, guys, that people should have to be forced to uproot everything and move away from all their other family, everything they've ever known, just for healthcare. I mean, but that's essentially where we're at. Now, when you don't do it, bad stuff starts happening. I know we're time. This is the number of hospitals in every state. I've looked at every hospital in every state. There's your numbers. Texas got a lot of hospitals, okay? But they got, that's exactly, now you start figuring it out. They got the worst insurance rate, but they got the most hospitals. That's right. More hospitals, more problems, baby. California has a ton. Now, we'll see a trend here in the next slide. So we'll start looking at this. So total hospitals, if you ever wondered how many hospitals, it's give or take a little over 5,000, depending on classifications. These are just fast facts from the hospitals, but 58% non-government or not-for-profit, 24% investor-owned, 19% state and local government. And we'll look at this. So you can look, 2/3 of the community hospitals are system affiliated. 68%, again, you can see here, and then 32% independent. Again, that's where you get your number from. If I added 3,514 plus the 1,643, a little over, you're right at 5,157. Now, here's your urban versus rural. This is becoming a rapid problem. You see why in the next slide. Got 35% are rural, and they are taking a dive, ladies and gentlemen. These are your hospital closures. This is every hospital in the United States has closed since 2005. This map is updated once a month through what we call the Shep Center at University of North Carolina Hospital. So if you look up UNC Shep Center, you'll get the link to it, you'll get this, and you'll be able to look at the hospital closures. We know what the predicted closures are. Mississippi, we've got quite a few right now. Texas has a ton on deck that are looking to close. Notice where the concentration is. Again, by and large, it's the South. We have a lot of critical access hospitals. So what the South is having to consider now in Mississippi is if they're a critical access hospital and they maybe have 25 beds, they're starting to close their beds, because if they close the beds, they can keep the hospital open, because then they get a rural health designation so they can get more money to have the hospital, basically an ER, but they just can't have inpatient rooms. So they're sacrificing the inpatient side just so they can have a facility. And this is, again, a little frustrating, but to your point, we start bringing all this data together and making it relational. Food, if you ever wondered, 57.1% of all places to get food are convenience stores. Grocery stores only make up 30.2%. Yeah, exactly right. And so then we have it broken out to where you can look at it in 2015 and 2019. Large grocery stores, the number did increase a little bit, but you can look at totals. And again, this gives you the low income and low food stores. You can actually break this map down, and I did not because it gets very granular, but by county and then by income level, you can overlay it to what we were talking about. And what you'll see is, in the poverty-stricken areas, they have less access to food, and the food they do have access to, yeah, it's trash. It's not healthy. Yeah, fast food, and people eating fast food out of convenience, and it's cheaper to eat unhealthy. Okay, I like oatmeal cream pies better than anybody. I'm just saying, I like them. Little Debbie, I don't like her. She likes me though. In 2019, 40% of the U.S. population lived more than 1 mile from a food store. And so I thought this was pretty interesting that you can see here is most racial and ethnic minorities live closer to food stores than white residents. Now, the problem is they live next to convenience stores. It had nothing to do. It wasn't a grocery. It was not a Whole Foods, let me assure you. Definitely not. Individuals and households with fewer resources tended to live closer to the nearest food store. Again, we can overlay this to SNAP benefits, Medicaid, things like that. And we start seeing some of these trends. The other unique piece that I overlaid this is pharmacies. Now, pharmacy not as much, because people think the mail order pharmacy is the answer, which it's not. But you can start to see people's availability for a pharmacy and how far they have to go to get drugs. Not the same drugs we get in Mississippi, but just saying. That is the last slide I have. I mean, are there any thoughts? And again, this presentation's goal was not to end up with you to have a ton of, the answer to everything. It's to look at things a little more broad and then narrow down and say, okay, I've thought about that one piece before, but we get very narrow focused on one thing, but there could be some other influences over here and over here that we may not think about. And so you bring those together. I think the Washington, D.C. area, I would like to look at, Washington. And what's interesting about Washington, D.C. would be to look at some of it when sessions are in versus when sessions are out. Because I bet that's a huge population shift in and out, and then going out to like Manassas and stuff and looking at a little bit bigger area. So are there any thoughts, questions that anybody has? I know it's a lot of data, but you'll have access to it. Again, not meant to digest, but when you guys start referencing it back, I think some of it'll make sense. And even decisions that we make as a business, especially, a hospital, providers, healthcare, we can use this information.